to PharmacyToDose, the Critical Care Podcast. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. And we are coming to you from the Orange County Convention Center in Orlando, Florida. What an exhausting Sunday of SCCM Congress activities. What I'm going to do, I will highlight some of my talking points from the kind of pro-con debate on alcohol withdrawal management, and then the episode will finish with a discussion of the one, the only, the amazing Joanna Stollings coming on to highlight the focused update of the PADIS guidelines. They snuck that in on us on Friday, and Joanna actually let me know during her roundtable today, because she presented, they released it in one of the afternoon sessions. So I reached out. I didn't know about it. I was like, I kind of wonder. It's almost like a Friday news dump. It's like, were you hoping we missed it? But great stuff in there. Joanna gives tons of insight, not only with her just knowledge, but also experience and being vice chair on that task force. But a great Sunday, kind of first full day of the Congress. So let's get going. So my session was this afternoon, benzos or barbs, current controversies in the management of alcohol withdrawal syndrome. So first things first, man, was the room packed. That was really cool. Shout out you all, listeners, friends of the pod. Definitely felt loved. Way more loved than the choice of drug that I had, because I had to argue pro-benzodiazepines. So everyone I talked to before, I told him, I was like, I'm getting creative. I'm mentioning drug shortages. I'm doing all the things to try to make my case. So essentially the way it was broken down, it was myself and Dr. Cassidy Dawn from the NYU Langone Medical Center, and she was arguing pro-barbiturates for alcohol withdrawal. I'm arguing pro-benzos. So to set the scene, the moderator started off and asked the room what they like to use for treatment, and I got to think it was 98% of the room put their hand up for barbiturates. There were a spattering of people that said they were pro-benzos, and then a few undecideds. So it was one of those, like, I knew the room was against me, but it was visualized to me very early that was the case. But so the way it started off, we kind of had a few questions, but we kind of had opening points or things we were going to make. So I want to lay out some of my case, right? Keep in mind, I guess I should clarify because we didn't say this. I'm a pro-barbiturate practitioner. I like using them in severe alcohol withdrawal. So being pro-benzos was certainly a challenge. But I joke in pro-con debates, right? Keep your friends close and your enemies closer. So my opening point, right? Benzodiazepines should remain first-line treatment. They are the most studied agent or class of agents for monotherapy and combination treatment of alcohol withdrawal in terms of both safety and efficacy. So the most evidence in treating some of the severe complications, right? Things we're most worried about, like seizures or delirium tremens, benzos have the most evidence for it. And despite being recommended for use in alcohol withdrawal and severe alcohol withdrawal, there's only 2 RCTs researching this question. They're ED studies, and one of them we instantly need to exclude because it's looking at mild to moderate patients. So then we have one kind of phenobarb in combination with lorazepam-based treatment study. And if you're like, wow, that's an interesting study, go back. That was a trial of the week. We had the Joseph Lamb come on, the pharmacist, on that 2013 paper to talk about his experience and things. So definitely recommend for people to go back and listen to that episode. Now, kind of back to the recommendation. So phenobarb is recommended to be used in severe alcohol withdrawal. Now, most evidence is with adjunct treatment, right? We're giving these in addition to benzodiazepines. So how safe of an agent is this if guidelines and drug references only recommend using phenobarb by quote-unquote clinicians experienced with phenobarb therapy? That's kind of a strange, it's not nomenclature you really see in other guidelines or drug reference things, so it kind of stands out to me. So then we have dosing challenges, right? When in the time course of their alcohol withdrawal should we administer it? Like, depending on the dose, do you have to have it made in the central pharmacy? What dosing weight are you going to use? Right, we're supposed to be using ideal body weight, but what if you're in a hurry and you dose it on actual body weight, right? I'm from Indiana. We got some Hoosiers, so that number might be double if you do that. And then, to me, this is by far the biggest question. If they're still agitated, what can we then do, right? Do we repeat the dose? Do we repeat it at a lower dose? Do we give a different agent? Like, we don't really know. And plus, there's less evidence on the safety of using with other adjunct agents like dexmedetomidine or even propofol, right? There's one study looking at dexmedetomidine with phenobarb, and it's from some pharmacy colleagues out in California. Now, the other thing is the monitoring or the scoring scale or scoring system. So we've made the argument for symptom-triggered treatment in alcohol withdrawal for the longest time. But when you're using phenobarb therapy, it's a little challenging. What is our optimal treatment strategy? Do we front load? Are we doing mini boluses? Can we use monitoring scales like CYAR or MINDS or RAS? Can we down titrate our treatments, right? And if they're still in severe alcohol withdrawal, if we're only supposed to use it for severe alcohol withdrawal, do we have to change to another agent? Now, one thing too, this is something I think most people kind of remember when you think of phenobarb. It is a potent CYP substrate. It's a strong CYP3A4 inducer, and that creates a multitude of drug-drug interactions, many of which can be significant for the critically ill patient, right? So let's highlight a couple of those. Midazolam, right? Literally the treatment that it's in tandem with. It can reduce that. Amiodarone, fentanyl, ketamine, quetiapine. Now, ketamine, I need to be clear, that's only in the oral route, so when we're using it parenterally. But then we have other things like methylprednisolone, right? Well, if they come in a COPD exacerbation, or DOACs, specific ASMs like phenytoin, phosphenitoin, or even lacosamide. So a lot of drug interactions. And the other question is, can we use TDM, right? Because the answer is technically no, but when we're using it in status epilepticus, right, we know we have the idea of a goal range of 10 to 40. So it would be really nice, right? They're talking about these first level kinetics, predictive. It would be nice to have kind of a goal range or a goal target, and that's not necessarily something that we can do. Actually, a question came up like, what do we do with those levels? And it's like, nothing other than get 800 alerts about how high they are. Now, the other thing I kind of brought up, right, in this era, we need to be familiar with it. What do we do if it goes on shortage? We don't have alternate agents like we do with benzos. And then a couple other things, right? To me, educational strategies are essential for implementation if you're going to do a phenobarb-based alcohol withdrawal protocol. You got to educate all team members that'll be involved, providers, nurses, pharmacists, right? You want to make sure the central pharmacists are aware. You don't want them rejecting this order for an agitated patient, and then providers get frustrated because treatment's not getting started because orders are getting rejected because they're not familiar with the new dosing scheme, right? Ideally, you'd think the EM and crit care colleagues would work semi-together to help kind of be on the same page with how it's used. And then you always want to look at your own institutional data. If you implement a protocol, look back and see how it's doing. Do you need to tweak it? That's one of the biggest recommendations when other people have come on talking about what to do with their own local protocols. Dosing weight education. And another thing to me is educate nurses on what those common doses might be. Make sure they're comfortable giving them with a drug that has some side effects like this. Now, to me, the other thing is when you kind of dive into this, you realize what a house of cards our whole alcohol withdrawal treatment data is. And there's a lot of research priorities, but to me, the three that stood out is what's the first line agent in critically ill patients with alcohol withdrawal, right? And then what's the most effective dosing strategy? Do you front load them? Do you do symptom triggered, IV to PO? And then finally, a clinical trial network to have less single center retrospective research. I feel like I made the best argument that I could, but of course I want people to know in severe alcohol withdrawal, I like using phenobarbital. And this was one of those where you dig in, and I felt more strongly about that case as I looked at some of the data here. So feels like definitely more to come, but that was a really, really fun session, and it was so cool seeing how many people came, kind of cheered and things like that. That was really great. It means a lot. I appreciate all of you. Now we'll take a quick break. Welcome back Joanna Stollings to talk all about the PAD-IS guideline update. So excited to welcome back recurring guest, friend of the pod, the famous pharmacist runner herself, Joanna Stollings, MICU pharmacist from Vanderbilt. Welcome. How's Congress been treating you so far?
It has been so fun, Nick. It's been busy. It's been going 24/7, like since I got up this morning till now. I don't think I've stopped. It's been busy, but fun.
Now, last time you came on, one of the things we asked was how many miles you had ran. So we have to ask, up to this point, what's your mile tracker at right now?
I mean, I only ran 5 miles this morning, but I do plan to get 6 miles each day. So on Monday and Tuesday.
I like that you consider yourself 5 miles being like a slow day, or you took it easy, like a pace and space kind of day. Now, are you going to do, I saw in the program that there's like a walk run on either Tuesday or Wednesday morning. Are you planning on taking part in that?
No, I honestly didn't even know about that, or I probably would have.
Well, the only thing is the distance was so low. I was like, Joanna might have seen this and been like, nah, I'm going to do my 7 and I'll see y'all when I'm done.
I mean, that's probably true. I'll probably get my miles done so I can go get my talk done before I have to leave, unfortunately, on Tuesday.
Now, we're here. Some people may know, but others may not, that we're recording this. It's Sunday the 23rd. And on Friday, February 21st, published in SCCM is a focused update to the clinical practice guidelines for PADIS, for prevention and management of pain, anxiety, agitation, sedation, delirium, immobility, and sleep disruption. I didn't even know that it had happened until I'm sitting at your round table today and you say it. And I'm like, well, we got to come on. I can't be alone. So number one, congrats. We sitting across from me is the vice chair, Joanna, of the task force. And then we definitely need to shout out Jeremiah Dubé and Patricia Lozen for also 2 pharmacist members of the task force. So really, really cool. Congrats.
Oh, well, thank you so much. It was honestly such an honor to be invited to do this, and it was really, really fun. And it was fun to work with Jeremiah and Patricia. They both did such a great job.
Now, how long, this is an update to the 2018 guidelines. So how long, have these been essentially in the works since 2018?
Not since 2018, but I think it's been just over 2 years that we've been working on them.
And it makes sense because you kind of think about it from when the data was reviewed from the last one. There have been a lot of PAD-IS related studies, like high quality RCTs that obviously are playing a part in some of these recommendations.
Absolutely. That's why SCCM is making these like a more focused update so that we're more on it. And we're only allowed to make like a few different recommendations versus 30 recommendations that they made in 2018, just so we can get them updated more quickly.
Well, and so these have 5 recommendations. Mm-hmm. So we'll get to them in just a second. But like, how do you ultimately determine that? Because you mentioned you have a topic as big as this. There's probably 100 things you want to try to look and see what we can recommend, or if there's positive change that we can make.
I mean, you're 100% right. It was hard. Like each member of the committee was like submitting ideas of things that they thought would like be important with regards to like new literature that had came out, and these were the 5 that essentially like the group thought were the most important to talk about.
Yeah, and so we will let's kind of get into what those kind of 5 recommendations were. And so I like to in the text, the table 1, it kind of breaks it out by the letter essentially of the PAD-IS kind of acronym that it's representing. So anxiety, agitation, delirium, immobility, and sleep. So we now instantly right away, wait a second, I thought it was PAD-IS. You just said this AD-IS. What's happening there?
So we didn't think there was enough significant of a change with regards to pain to put anything there. So we essentially, with regards to the A, which is agitation and sedation, we had to like tag anxiety on there. It thankfully started with an A. It made it easy, just because we thought that wasn't enough important of a topic to address.
Yes, and we're gonna put a pin in that because I think that was something that stood out as kind of being addressed when we've had multiple iterations where it hasn't necessarily been. So let's get into these 5 questions. So the first, does giving benzodiazepines for anxiety treatment of ICU patients, should we be doing that? That's kind of the question number 1, correct? Number 2, in mechanically ventilated adults, dexmedetomidine versus propofol. I know, y'all, these are, and it gets better. In number 3, delirium, should we be giving antipsychotics? Number 4, what's the role of PT in early mobility? And then number 5, this is where it feels like it's really spicy too, is should we be still giving melatonin as a sleep aid? So those aren't easy slam dunk. These are questions that I feel like you would argue have no black and white answer. And I love that those were the ones you all tackled.
Oh, thank you.
So because there are 4 pharmacologic and 1 non-pharmacologic. So are there any and we'll kind of get into like the research ideas, but how did the discussion go as you were trying to pick? Was there emphasis in one letter over the other, or like how was that? Because when you have people of different disciplines, everybody's going to think a little bit more, right? Like they might be worried about, a procedure X, Y, or Z, where we might be, pharmacists may think more of meds and things like that. Mm-hmm. How is that process?
I mean, honestly, like we wanted to represent one question from each letter, but then very wise nurse Michelle Ballas brought up the whole anxiety thing. And the more and more we thought about it, we're like, hey, this is super important. Like maybe it doesn't really have a letter. We've kind of added that into the A, but this is important enough that we need to address it. But that was kind of how we came up with the questions.
Now, what role, because I always think this is so cool when there are patient advocates, right? People that have experienced it. So what role did they play in, did they have any role in like what you all ultimately like focused on? Because it stands out to me, you have 3 members and then you kind of focused on a new sort of intervention or idea in these guidelines.
I mean, absolutely, they did. Like they, obviously, since they're not in the medical field, then they weren't as familiar with maybe coming up with the questions, but once we came up with them, they did agree with them and why that we thought they were important.
I think that's so cool because sometimes we can get caught up as ICU, team members of 90-day mortality, all these things where it's like the patients are going to bring up things that matter to them from a morbidity perspective that we just might not think of. So I always think that's cool when you're able to get all those different ideas together. So before we get into the recommendations, which one was the most challenging? Or maybe you can say which one was the easiest to make, like to kind of reach a consensus? Because I'm guessing for some of them may have been easier than others.
You're 100% spot on. I feel like you may have been spying in the room. So the anxiety was absolutely honestly the most easy because there's no data, So that one made it very easy. There was no controversy, like the only controversy with that one was, hey, should we look at this? But when we thought about it, we were like, hey, yeah, this needs to be evaluated and be made a call to action, essentially. The hardest one was hands down the antipsychotics with delirium, for sure. Very controversial. Definitely talked about a lot.
So let's start with anxiety. So how much of this, how much is this an actual problem for our ICU patients?
I mean, I think anxiety is a huge problem for our patients. Like if I was a patient in ICU, I would be anxious, like here you are, you're in an unfamiliar environment. You have all these unfamiliar people taking care of you. You're being poked and prodded. And I think it's a huge problem.
Yeah. And it's one of those that I think we all think of like, oh, the breathing tube's painful, right? That whole thing, I think it's pretty easy to say you would have anxiety in that same kind of situation. Now, so you mentioned their recommendation that you couldn't kind of come to one essentially. Why do we think there's only one study? I'm sure you all didn't expect that. Like what do you think a reason of that is like having issue with actually having a scale for like measuring or identifying anxiety? You
hit the nail on the head is we don't have a scale for that in ICU patients. Like this really is a true call to action. Like we need to be able to better to identify this in our patients. And we also need to, once we've identified it appropriately, figure out like what's the best way to treat it. And apparently, I didn't realize this, but they're at the same time that this was being released, we'll say, into the meeting earlier today, there was actually a study looking at propranolol for anxiety that was being talked about at the same time. So I have not had time, honestly, to look at that, but that's exciting. It's almost like, hey, did they know that we were thinking about this and they did this study? So I'm excited to read that.
And I like that it's pointed out at the end that for those who are chronically taking benzodiazepines, you may need to continue that to prevent withdrawal. And I like, sometimes you have to state it out for people to finally buy into the things that we've been, hollering on rounds. So I love that kind of addition to that. Now, the next recommendation, it's going to be of interest, I think, to some ICU pharmacists listening here. So what does the task force suggest as your first-line sedation?
Dexmedetomidine.
Let's go. So now, what led to this? Because this is a change, right? The 2018 recommendations, they suggest using either propofol or dexmedetomidine over benzodiazepines for sedation. So talk through what kind of went into that change.
I mean, there's been a lot of data that has came out with regards to dexmedetomidine in the last few years. I mean, we have SPICE-3, we have MENS-2, just to name 2 very big studies that came out. So there was just an extreme amount of data. We thought it was important to reevaluate this question.
Now, there's tons of pros, right? I'm a pro dexmedetomidine, so like reduce prevalence of delirium, may reduce the duration of delirium,
Absolutely.
may reduce the ICU length of stay. Is it all positives? Was there what's something that maybe will make us kind of hesitate a little bit on using this just kind of blindly for everybody?
I mean, the biggest thing, and I think any person that has used dexmedetomidine before has seen this, is the bradycardia, And so, but I think that you have to remember this, and we were really thoughtful about this when we did the men's 2 trial, is remember, it's not just bradycardia. Like me as a runner, we talked about this. My heart rate's probably 40-something right now, and I'm just fine. Is it symptomatic bradycardia? Do they drop their blood pressure too? So I think it's very important that we remember that.
That's a really, really good point. And I like, too, that you added, while dexmedetomidine may be preferable, clinical judgment must be used. That feels like an important phrase when you think of recommending like a first-line agent for something as common as, people being put on the ventilator.
Right. I mean, I think the biggest thing is, and once again, anybody who's used dexmedetomidine can attest to this, that sometimes, unfortunately, our patients with severe ARDS, for example, are going to need deeper sedation, and you're just not going to get there with dexmedetomidine, so that's where you would have to consider propofol.
And then as we're thinking of trying to make these more global guidelines, you kind of address the fact that, like, yes, for us here in North America, these costs are much more similar now, but that might not be the other cases in other places. And so you kind of have to take that into account if you don't have as, low of a cost as is the argument here, and why the argument of cost is becoming less of an argument.
Absolutely. I think you have to consider that too. And in resource limited situations, it may not even be cost. It may just be they don't have access to it either.
So one thing that, a question I think that comes up, how does age impact our decision? Because for the listeners, the SPICE-3 subgroup kind of found increased mortality if you're using it in those who are younger than 65. So what did the task force what did you all find with that?
So we did not find that signal when we evaluated that, but it is a very important research question. So important that the investigators for MENS 2 are actually taking our MENS 2 data right now and looking at that exact question to see if we find the same signal. And obviously, if we do, then it's just going to be essentially like telling us that we need to do a prospective randomized trial to find out if that indeed is true. This powered appropriately. Yeah.
And, the listeners, if you haven't gone back, John Devlin joined to talk about one of his trials of the week, and he had kind of mentioned some of the methodologic issues with SPICE-3. That's something you've brought up as well. And so I think most of us would say that MENS 2 is higher quality, so getting the subgroup from that, I think, will be a little more telling. It'll help us kind of probably figure out if we're in the right direction or not. So that's awesome.
Thank
Love
you.
that.
Thank
That's
you.
Breaking news right now. All right. Next recommendation. Somehow we just talked about dexmedetomidine versus propofol, and that wasn't even the most controversial one.
Not at all.
So should we still be using antipsychotics for ICU delirium treatment?
So this is a very heated question, as you can imagine. So full disclosure, I'm a Mind USA investigator, right, where we found a very, very negative study with regards to antipsychotics compared to placebo. But since then, the 8 ICU study has been published, and a secondary outcome essentially showed that that using antipsychotics actually decreased, Haldol specifically, decreased mortality. And so the reason, it's one of those things, like, you got to evaluate the data you have.
Yeah.
And so if antipsychotics indeed do decrease mortality, we thought it was important to talk about it. But just being real, all of us were mind blown because we were like, how does this make sense? It doesn't decrease delirium. It doesn't decrease time on the vent. It doesn't decrease time in the ICU. Like, logically, how does this make any sense? So we thought it was important to be honest. We have the data. We need to share it. But no, we don't understand it. And no, I'm not going to go recommend in the Vandy ICU tomorrow that we start using antipsychotics, because I don't think that we should. I did think it was appropriate we shared this data because we had it.
And I wanted to point out, right, that the reasoning is different for this of no recommendation compared to the anxiety treatment. There's no recommendation because you have one pre-post study. Shout out some pharmacists from Ohio State, right? Pharmacists
Exactly,
being the only published study there. But this, right, we have a lot of high quality stuff. And so I like that you kind of highlighted the differences and point out that this is nuanced stuff. Mm-hmm. It is really, like, delirium is so multifactorial. We still are figuring out all of the causes and how. So I appreciate kind of explaining the nuance and all the things with it, and being sure that like you don't want to say that and everybody starts giving it to everybody, right?
That would be a nightmare. Yeah, this needs to be further hashed out. Like both Aid ICU and Mind USA have hypoactive patients, but we specifically probably need larger studies in those specific subgroups to further give us the correct answer with regards to this.
So was there any discussion on like the class of antipsychotics, like versus, you mentioned the Mind USA was ziprasidone, right? The classic like atypical antipsychotic, Aid ICU, the typical antipsychotic with haloperidol. Did you all look at it as a class, or did you think about any of like, or did you do it as like the subgroups between the different antipsychotics?
Well, Mind USA, remember, was haldol, ziprasidone, and placebo.
Oh, yes.
Yeah.
Okay.
And then
okay.
Aid ICU was just haloperidol.
So as a class then?
Yes, as a class.
All right. And so this feels like the one where there's more info coming, or there should, and we'll kind of get into research priorities, but that feels like one of the bigger kind of hot button things to try to sort out.
100%.
All right. Now, there's one non-pharmacologic recommendation.
There is.
All right. Let's shout out some of our favorite members of the ICU multidisciplinary team, our physical therapists. What's the recommendation with PT and mobility?
It essentially recommends doing enhanced mobility over normal practice. So everybody's like, what's this enhanced mobility thing?
You read my mind.
So enhanced mobility essentially is just taking the next level, doing like what you would, one step up from what you would do on a normal patient.
So let's use an example. Let's say normally I get the patient in a chair position, whether it's in the bed or on the side of the bed. So would enhanced be like they're like cycling a little bit, or like what does that look like for us non-PT folks?
It might be they're cycling. It might be, we called it the horseshoe during COVID when they would like walk around the bed, Now they can walk in the hallway too. But yeah, it's doing like, you got to start basic, sit on the edge of the bed, stand up, get them to a chair. The next step up would be walking somewhere.
Okay, we hit 4. The last recommendation, it looks at an intervention that I would say anecdotally a lot of people are using. But so the question is, should we continue using melatonin for our ICU patients?
The data showed that it decreases delirium, right? And it also increases quality of sleep. So I think this has been a question that a lot of people have had. And like you said, unfortunately or fortunately, a lot of people do this, just because we know that we want our patients to sleep more, just because we know that them not sleeping can put them at risk for delirium, and that's obviously risk factors for cognitive impairment, mortality, etc. So the tricky part with melatonin is like, you don't know what you're getting necessarily. It's not regulated by the FDA.
Yeah, why is that? What's the big difference between melatonin and, say, if we were to give someone quetiapine or trazodone?
Exactly. So quetiapine and trazodone, like if you give 25 milligrams of quetiapine, you know that every patient's getting actually 25 milligrams versus melatonin. You're like, oh, let's order 2 milligrams of melatonin. Maybe they get 2 milligrams. Maybe they get 1 milligram. Maybe they get 5 milligrams. It is not regulated.
And the percent of when they've like done, I think it's like the natural formulation, something when they've looked at it, it's everywhere from like single digits to like 90%. And in the era of us buyers and contracts, it's hard to even control what brand you have.
Exactly. Yeah. It gets tricky. I think the biggest take home point from this too that I want to make sure I say is I don't want people to forget about the non-pharmacologic things, to forget to like stop waking people up in the middle of the night to like do labs or give a random medication or whatever, if you don't have to. Like, yes, melatonin may be helpful, but don't forget step number 1. Step number 1 is non-pharmacologic treatment of insomnia, and if that doesn't work, then do the melatonin.
I kind of think of sleep and delirium a little bit interlinked in some way, and it makes sense because the non-pharmacologic stuff is everything that works for delirium, so it makes sense that the sleep would be kind of the same way.
I agree.
Question about dose. What dose do you like to use of melatonin?
I'm a baby dose kind of girl. I like 2 milligrams, 3 milligrams.
So explain, because we talked about this at the round table, and most of us said 9 or 10 milligrams. Explain to you why maybe we should possibly be changing our practice of kind of hitting peak melatonin right when we start it.
If you use higher doses of melatonin, there's actually data that can make you sleep poorly. So you really should stick with a smaller dose of melatonin.
All right, so that is literally proven wrong, something that I've always kind of argued of like, well, if you're going to start it, go big. So we will report back to the pod when those things change. One of the things I love about the SCCM guideline updates, the new ones, is that there are things like research priorities, like things especially as, right, this is end of February. People are starting to plan for research projects coming in the upcoming year. So what are a few highlights of like the PADIS research agenda? Because there's 17 individual items. We won't go through every one, but what are things that stood out to you?
I mean, I think the biggest one is like anxiety. How do we identify it? How do we treat it? Like, that's got to be evaluated. I don't think embarrassing is the right word, but there's one study, right, that has looked at treatment
kind
with
benzodiazepines for something as common as that.
Yeah. So absolutely, that's got to be at the top of the list for sure. And then I think with the dexmedetomidine, the age thing that we talked about earlier is a big priority with regards to that. I think with the antipsychotics, specifically looking at hyperactive and hypoactive delirium is another big one to consider for sure. Those are probably the biggest three if I had to pick that I would put.
I'm sure even narrowing it down to 17 was challenging.
It really was. There was a lot to think about for sure.
Is there something that, because when you go into this process, right, a lot of us, we have ideas on what we like or don't like in the literature. Was there anything that when you evaluated it that kind of like changed your mind, or you had a changed point of view after you dive in? Because for the listeners, look in the supplementary appendix. There's like 50 pages of how they searched for these things. So this is this is as thorough of a PubMed, all the review as you can.
Right. I guess it did make me like, I'm absolutely for sleep. I'm still obviously going to do all the non-pharmacologic things, and I am a melatonin first line kind of girl. But it made me, if I'm getting any kind of negative feedback from someone, like, hey, like there's not data to support that, I can be like, hey, actually, there is, So I think that was a big one. The antipsychotics, I don't think is going to change my practice at all. If anything, that one, like I said, was just frustrating because it just doesn't make sense,
That was the one you led with. It was almost like unfulfillingness. And I'm sure you wish you could have had recommendations for everything. And that was probably the goal. But sometimes the best research isn't necessarily positive ones. Sometimes, right, the best thing is identifying that we have one study in the anxiety ward, or we really need to narrow down X, Y, or Z.
Right.
Okay. If you had to sum it up, what are some of your biggest takeaways from these guideline updates, things that we want to be bringing back to our institutions?
Bring back to your institution dexmedetomidine is where it's at. From a sedative standpoint, like, who doesn't want to prevent delirium, decrease duration of delirium, Like I said, bradycardia does happen, but you got to check and see if it's actually clinically relevant bradycardia. So that's a big one. I personally wouldn't change our practice with antipsychotics. Early mobility is where it's at, so not early mobility, I should say enhanced mobility. So this is kind of also like a call to action for everyone. Say, why not try to take it to the next level on even just a few patients in your ICU, so that we can enhance our mobility practices in the ICU. I think that's another big take home. If you are in a conundrum, your patient won't sleep, you've done all things non-pharmacologic, and you're like, which agent should I choose? I think now you have an answer. You shouldn't be picking quetiapine first line. You shouldn't be picking trazodone first line. You should be picking to use melatonin,
Yeah.
So I think that's are the big points for sure.
Joanna, anytime you come on, we get to learn from you. It's an absolute pleasure. Thank you. Congress update, or not Congress update, race update. What's in your future? What's on? When's the next time you're lacing them up on a Saturday morning?
So I'm actually lacing it up on a Monday morning. So I'm running the Boston Marathon on April 21st.
That's amazing. I need to give you your flowers here, because a lot of people, if they haven't necessarily looked into marathons, they don't understand. It's like, oh, my brother-in-law has done the New York or Chicago. You have to qualify for Boston. You have to be a really good runner. And so that's awesome.
Thank
All right.
you.
So, because that's, Patriot Day, right?
It is. Yeah, that's impressive.
Okay. Last question. What's your carbo loading meal before a marathon?
I mean, believe it or not, I like to nerd out on this stuff. You actually have to carb load for about 3 days. I'm not kidding.
It's when people carb load the night before, I'm like, you're just wrecking your Sunday.
Yeah,
it's not helping you at all. It's actually probably going to make you wake up and like have a pit in your stomach. You know, Michael Scott from The Office.
Exactly. So it's like a 3-day process where there's a lot of pretzels, there's a lot of bagels, there's a lot of pasta, anything that you can do, and also sports drinks. Just because, like you said, you don't want to get really like super bloated beforehand.
Yeah.
But yeah, the night before isn't like necessarily where the magic happens. Those 3 days.
Joanna, thanks again. Reminder, everyone go to Critical Care Medicine. We'll have links in the episode description, the focus update to the PADIS clinical practice guidelines for ICU patients. So thanks, Joanna. Appreciate you.
Thank you so much, Nick. This was really fun.
Another huge thanks to Joanna Stollings for coming back, talking about these guideline updates, vice chair of this task force. And remember, Jeremiah Dubai and Patricia Luzon are 2 other pharmacists on those guidelines, so be sure, got to give them their flowers as well. And then, of course, want to shout out you all, friends of the pod, listeners, coming and supporting me during my talk definitely was great. So I hope you had some fun. Those are my favorite kind of talks. I'll be around. Today was by far the busiest day. Tomorrow's busy, but less. So excited. And be sure to come. Brian Gilbert and I are moderating a roundtable to connect to Place First TPA. So come say hi. Until next time, I'm Nick Peters. This is Pharmacy to Dose, the Critical Care Podcast.